Good
Yes,
evening,
please
everyone,
continue.
and welcome to the today's session, a CNS case presentation. And today's case presentation is by the first year DNB Family Medicine resident of Kamineni Hospital, Hyderabad, Dr. Srivardhan. And I heartily welcome our moderator, Dr. Kiranmai, ma'am, who is a consultant family physician and diabetologist, KL Health Center, Hyderabad, and a visiting consultant and family physician at Tenet Diagnostics. She is a current AFPI state president, Telangana. She is a clinical examiner for MRCGP International South Asia Board. Welcome, ma'am.
Thank you, Guru. Thank you very much, Guru. Today, we're doing an interesting session on stroke. As we all know, it's kind of a stroke is a medical emergency, and it's a very important and frequent presentation in our clinics. So dealing with it effectively and immediately is one of the most important things we have to do as a family physician. And we also know that stroke is a major cause of second leading cause of death worldwide. So it's a very important thing to identify stroke and manage it immediately and effectively. It is also the fourth leading cause of death in India and the fifth leading cause of disability. Hence the importance. So let's start with the presentation of a clinical presentation of a case by Dr. Vardhan. Virup, can you introduce Vardhan?
Yeah, ma'am. He is a first year DNB Family Medicine, Kamineni Hospital. Dr. Srivardhan, please start.
A 58-year-old male patient, a resident of Vijayawada, who is a government employee in APTS by occupation, he came with the chief complaints of giddiness since one day and slurring of speech and weakness since 11 a.m. The patient was apparently normal one day ago. Then he developed a sudden onset of giddiness, which he described as lightheadedness, while doing brushing at 3 a.m. In the morning, which lasted for about 2 minutes, which is not associated with any postural variation, no aggravating and relieving factors. And he had 2 more episodes the next day, which were about 2 to 3 hours in duration. The dizziness is not spinning type and not associated with any oral fullness, tinnitus, vomitings, hearing loss, palpitations. And he also had a slurring of speech and weakness of right upper and lower limb since 11 a.m. in the morning, which is sudden in onset, gradually progressive, and swaying to left side while walking. The patient was having difficulty in combing the hair, difficulty in buttoning and unbuttoning, difficulty in getting up from sitting position, difficulty in gripping the chappals on the right side. The patient was able to roll on the bed, no associated involuntary movements, loss of consciousness, headache, fever, neck rigidity, no difficulty in understanding and conveying things, but associated with slurring of speech. The patient had slurring of speech since 11 a.m., which gradually progressed, but no visible deviation of mouth observed by the patient, not associated with any drooling of saliva, not associated with any nasal regurgitation of food, able to chew and swallow the food properly without any difficulty. The patient has no altered state of consciousness, changes in memory, state of alertness, drowsiness, no hallucinations and delusions. The patient was able to see the things clearly, no double vision, able to feel the taste, slurring of speech present, but he is able to close his eyes and he is not, sorry, this was a mistake. He was not having any drooling of saliva. No history of numbness or abnormal sensation in the body. No sensory abnormalities, and he is not having any autonomic abnormalities, no history of voiding, defecation difficulties or palpitations and sweatings, no history of abnormal movements or postural stability. Coming to the past medical history, the patient is a known hypertensive since 7 months, and he is on telmisartan and hydrochlorothiazide combination and a CC amlodipine. And he's a known diabetic since 10 years, and he's on voglibose, glimepiride, and metformin combination twice daily, and he's a known dyslipidemic on atorvastatin 40 mg. and he had no significant family history, no history of any CNS complaints in the family. Coming to the personal history, the patient is on mixed diet, his bowel and bladder are regular, and sleep is adequate, no loss of appetite, no addictions, no allergic history, or no previous surgeries. Ma'am, can I present my differential diagnosis?
Sorry, yes, you can go ahead with it further.
So my patient is a 58-year-old male. He presented with the complaints of giddiness since one day, which is of he described his character as lightheadedness, and he has associated slurring of speech and weakness. Weakness is of right upper limb and lower limb weakness, and he had swaying while walking towards the left side. So based on this history, my differential diagnosis were cerebrovascular accident, because it is an acute onset, acute thing. I thought it is which is acute onset and gradually progressive. I thought it is an acute ischemic stroke involving the left internal capsule, as he is having right-sided weakness and he is having a slurred speech while talking. So I thought it was maybe due to a facial nerve involvement. And he had giddiness with swaying towards the left side and associated with slurred speech. So I thought it may be due to cerebellar stroke. And he's having an right-sided weakness with slurring of speech. So I thought it may be due to a brainstem lesion, such as in Pons.
1 minute, Vardhan.
Okay.
And I welcome Dr. M.V. Sangamesh, sir, who is today's the chair and the chief guest, chief neurologist in the Veera Neuro Center, Hyderabad. He did his MD from the Kakatiya Medical College, prestigious college from Warangal, and he did his DM from the Musmania Medical College, Hyderabad. I welcome you, sir. Please go on, Vardhan.
So with these DDs, I did my general examination. The patient was moderately built and nourished. The patient is conscious, coherent, cooperative, and he was obeying commands.
Sorry to interrupt. Since our chief case neurologist has just joined, I think it'll be good if you summarize the case.
Okay, ma'am.
Yeah,
So my
summary and the DDs. Yeah.
Okay, ma'am. So my patient is a 50-year-old male who is a known diabetic, hypertensive, and dyslipidemic patient. He presented to the emergency department with the complaints of giddiness since one day, which he told to be as lightheadedness, which is of 3 episodes. And he had associated slurring of speech and weakness since 11 a.m. The slurring of speech was not associated with any deviation of mouth or drooling of saliva or difficulty in. There is no difficulty in chewing or swallowing the food. There are no significant other cranial nerve history or sensory history, motor history. But coming to the weakness is of right-sided upper limb and lower limb weakness, sir, and it is associated with it is sudden onset weakness since 11 a.m., which is gradually progressive, and the weakness is associated with swaying towards the left side. With this history, I thought it could be an acute ischemic stroke in the left internal capsule, because he's having a right-sided weakness and light-sided weakness, and the slurred speech, which may be due to facial nerve involvement. And I thought maybe the ataxia could be due to right-sided weakness, so he was swaying towards the left side. And the second differential which I kept was cerebellar stroke, because he is having giddiness and swaying to the left side, and he is having a slurred speech. I kept it as cerebellar stroke. And the third differential which I made was right-sided weakness with slurring of speech. So I thought maybe the pontine in pontine stroke with the seventh nerve involvement, maybe it could be ischemic stroke related there, sir. Can I proceed with the examination?
Yes, go ahead with the examination findings.
Okay, ma'am. So the patient is moderately built and nourished. He is a conscious, coherent, cooperative, and obeying commands. His vitals were stable. BP was 140/90 and pulse rate was 84 beats per minute. Respiratory rate was 20 cycles per minute. There are no visible external neurocutaneous markers. There are no atherosclerotic markers such as xanthelasma xanthema or any arcus annulus. No carotid bruit, no pallor, icterus cyanosis, clubbing lymphadenopathy. Coming to the nervous system examination, in higher mental functions, he is a right-handed person. His consciousness and memory were intact. He is able to understand the language. He's able to speak fluently. He's able to repeat the things, and he had problems with speech. The patient has difficulty in pronouncing the labials. There is no nasal twang to the speech. The patient speaks with gaps as if words are measured or scanned. The patient has no apraxia or hemineglect or other higher mental disturbances. Coming to the cranial nerve history, cranial nerve examination, he is able to perceive smell in both noses. And coming to the optic nerve, his visual acuity was normal, his color vision is normal, and his visual field was similar to examiners. Coming to the 346 examination, he is not having any visible ptosis, and he's able to see in all directions of gaze without any nystagmus. His pupils were bilaterally reactive to light and 3 mm. His trigeminal nerve, he is able to perceive the sensations all over the face. His motor, he's able to chew properly. His muscles of mastication were intact, and his jaw reflex was absent. Coming to the facial nerve examination, he had a loss of nasolabial fold on the right side and the deviation of mouth towards the left side. And wrinkling was present bilaterally, and he is able to close the eyes completely. Coming to the 8th nerve examination, his Renes was bilateral air conduction is more than bone conduction, and Weber's is not retroculated, it is in central position only. Coming to the glossopharyngeal and vagus nerve, his uvula is central, his gag reflex is intact. Spinal accessory nerve, he is able to shrug shoulders against resistance, and he is able to rotate the head side to side against resistance. Hypoglossal nerve, there is no deviation, fasciculations, atrophy of the tongue. The tongue is in the midline, that he is able to do all the tongue movements. Coming to the motor system examination, the attitude of the limbs, the right arm is in a slightly adducted and internally rotated position. Elbow is slightly flexed position and forearm pronated, whereas leg is slightly external rotated position. Coming to the bulk of the patient, the bulk is bilaterally symmetrical. There is no visible wasting noted. Tone, the patient is having hypertonia in the right side upper limb and lower limb, whereas there is normal tone on the left side. Coming to the power of upper limbs, I tested the power at shoulder, elbow, wrist, and hand grip. It is 4/5 on the right side, and it is 5/5 on the left side. Coming to the power on power on lower limbs, on hip, knee, and ankle, I have tested the hip flexors extensors, knee flexors extensors, ankle flexors extensors. It is 4/5 on the right side and 5/5 on the left side. Coming to the reflexes, in superficial reflexes, the corneal reflexes were bilaterally present, and the abdominal reflex was absent on the right side, but present on the left side. The plantars were extensor response on the right side, flexor response on the left side, and the reflexes and the deep tendon reflexes, they were 2+ on the right side and 1+ on the left side. They were only present with the manuals, Jurassic manuals. And coming to the sensory examination, the patient is able to perceive bilaterally pain, touch, temperature, proprioception, and the cortical sensations were intact. The patient is able to identify the objects, and his 2-point discrimination and localization were intact. Coming to the cerebral signs, he had an abnormal finger nose test on the left side, past pointing on the left side, no nystagmus, rapid alternating movements were abnormal, and swaying to the left side on walking. and he has an abnormal heel shin test on the left side. There were no meningeal signs, and the gait was he's swaying to the left side. Whereas coming to the other systemic examinations, the CVS S1, S2 heard, there were no added signs, there were no murmurs. Respiratory, bilateral air entry present, normal vesicular breath sounds, and no air sounds. For abdomen, it is soft, non-tender, no organomegaly. In summary, my patient is a known diabetic hypertensive dyslipidemic who presented with sudden onset right-sided hemiplegia with element left-sided UMN type of facial nerve involvement involving only the lower half of the face on the left side with deviation of mouth to the right side and right-sided hemiplegia due to CVA, probably thrombotic in etiology as it was progressive in nature, with the site of lesion probably the internal capsule and cerebellum. So the patient has the following risk factors: diabetic, hypertensive, dyslipidemia, and these are my positive findings on examination: the hypertonia, extensor Babinski's, and weakness on the right side, deviation of mouth to the left side with loss of nasolabial fold on the right side, and abnormal finger nose test on the left side, pass pointing on the left side, no nystagmus, a rapid alternating movement abnormal on the left side, swaying on the left side while walking, abnormal heel shin test on left side.
Right.
Can I proceed?
So Dr. Vardhan, is this done or you have next slide after this?
I have like what we did after
Okay.
after the examination.
Management, right?
Yes, ma'am.
Yeah,
like,
let's
yes, ma'am.
just figure out if anything else needs to be added here. That was a very detailed and extensive history and examination. Dr. Sangameshwar sir, anything you would like to add in the examination or the history which the students have to pick on, or anything abnormal or anything else you would like to add on?
Good evening, everyone. It's a nicely presented case, Srivardhan. So can I have the first slide?
Yes, sir.
Your chief complaint. Okay. Yeah. What is your chief complaint, Srivardhan?
Sir, the patient majorly complained of giddiness since one day and slurring of speech and weakness since today since 11 a.m. sir.
Yeah. Okay. So good. So you have 3 chief complaints. Here weakness should be specifically mentioned, whether it is a right-sided weakness or a left-sided weakness. Here you got your right-sided weakness, right?
Yes, sir.
Yeah. The weakness is non-specific term. You said right-sided weakness. Okay.
Okay.
So you have to elaborate these 3 chief complaints in your history of present illness. So let's go for giddiness since 1 day. What is your history regarding your giddiness? Positive and negative history.
So in giddiness, I inquired about the type of giddiness, sir, whether it was lightheadedness, whether it was a reeling sensation or a sense of spinning sensation of the surroundings, and whether it was like vertigo history or whether it was a presyncopal dizziness. I asked it, sir, whether it was associated with any postural variation while from sitting to standing, or whether it was associated with any head position change. I asked it, sir, whether it was associated with any oral symptoms, tinnitus, any BPPV associated, any Meniere's associated symptoms. I have asked it, sir, whether it was associated any vomitings. I have asked it, sir. I have asked about the duration of giddiness, which was about lasting about 2 minutes 1 day back, whereas today it was lasting about 2 to 3 hours, sir.
Achha. Very good. You have covered all the points. Can you tell me what is the difference between giddiness and vertigo?
So giddiness is basically a non-specific term, sir.
Okay.
It includes it includes basically the spectrum of things such as vertigo, lightheadedness, presyncopal dizziness, and yes, sir.
Okay. Yeah, you're almost there. See, giddiness or dizziness is a subjective feeling of maladaptation to the environment. As
Yes,
you
sir.
said, it is a very vague symptom. So
Yes,
it
sir.
has a varied etiology like postural hypotension. As you said, it is a pre-syncope, and many times it can be because of fatigue in anemia or psychogenic it can be. So if there is a spinning sensation, then it is called as vertigo. By definition,
Yes,
it
sir.
is illusion of rotation due to mismatch between the inputs from vestibular, visual, and proprioception. That is vertigo. Okay. So you have
Yes,
to
sir.
differentiate clearly in history itself, whether it is dizziness or vertigo. Now, what your patient has, it is vertigo or dizziness.
The patient was, I asked about the spinning sensation, sir, and I asked about specifically whether the character of the symptom he was not able to specify, sir. Whether I asked like, is your environment rotating around you, or you feel like the surrounding objects are moving around you, whether there is any spinning sensation or rotatory sensation of yourself or
You asked
environment. I
it. There
asked
is
it.
no spinning sensation. That's what you're trying to mention, right?
Yes, yes, sir.
So you say it is dizziness.
Yes, sir. But
Okay.
I feel like, sir.
But your negative history is completely related to vertigo. Like you have asked for postural variation. So how do you differentiate on history whether it is a peripheral vertigo or a central vertigo by history?
Actually, I took the history differentiating the peripheral vertigo and central vertigo also, sir. So the peripheral vertigo,
Yeah, go ahead. You asked in history.
based, yes, sir.
Yeah.
So there were there were any when we are differentiating the peripheral vertigo and central vertigo, usually we ask about any neurological deficits which are associated with the dizziness or vertigo, which is suggestive of a central vertigo. Whether there is any nystagmus or
No,
these
nystagmus
things.
is an examination. So
Yes, sir. Yes.
vertigo. So if there is any positional change, then it is in certain position.
Yes,
If the patient is feeling reeling sensation or spinning sensation, it points to peripheral vertigo.
Peripheral.
And
Yes, sir.
vomitings will be more and severe in case of peripheral vertigo than compared to central vertigo. And as you
Yes,
have
sir.
said, ear symptoms like heaviness or tinnitus, whether high pitched or low pitched, points to peripheral vertigo. And the
Yes, sir.
patient will usually sleep onto the one side. The affected ear will be on the higher side, like topmost. That is again in peripheral vertigo. Okay, whereas central nystagmus, central vertigo will not have any characteristic like this. Does not vary with posture, does not vary with the duration. So it is continuous vertigo will be there in case of central vertigo. And other neurological features will be there, which will be discussed further. You have that in the history. Okay, now you
Yes,
say
sir.
that it has dizziness only. You stick to
Yes, sir,
dizziness
dizziness.
or you feel it as vertigo.
I stick to dizziness only, sir.
Dizziness, there is no point in asking like
Yes, sir. For the
positional
negative.
variation. Yeah, there is no point. Okay, go
Yes,
ahead.
sir.
What is your next? And where do you localize central vertigo? So in neurology, Srivardhan,
to the brainstem
any
structure, sir. Usually the vestibular nuclei and these things will be situated in the cerebellum brainstem structures, sir, such as pons midbrain, these structures.
see, okay. Any final year PGs, your first year PG, right?
Yes, sir.
Will they also participate in this discussion?
If anybody wants to answer that, please go ahead. Any final year PGs?
Exam going PGs where anyone knows the answer can answer. In central vertigo, it is usually the vestibular nucleus which is affected. It is located in the pontomedullary junction. Even the inferior cerebellar peduncle and the cerebellar lesion can also produce vertigo, central vertigo. Whereas peripheral vertigo is usually because of the medullary disease, labyrinthitis, or vestibular neuronitis, or vestibular nerve itself can produce this kind of picture. So based on the age of the patient, duration, we should find out the etiology. In case of central vertigo, what is the etiology? What is the etiology in peripheral vertigo? Okay.
Okay.
Okay. Yeah. So now you think it as dizziness, and you go ahead with your second complaint.
So my patient had slurring of speech and weakness of right upper and lower limb, which was sudden in onset since 11 a.m. in the morning, which was gradually progressive, and it is associated with swaying to the left side, sir.
Okay. Yeah. Now go ahead.
The patient was having weakness of right-sided upper limb and lower limb, both proximal and distal muscles, sir. And he is not having any associated involuntary movements, loss of consciousness, headache, fever, neck rigidity, difficulty in understanding or conveying things. But he is having slurring of speech, sir.
Acha. So what do you mean by slurring of speech? How do you differentiate? What are the kinds of dysarthrias you know, and how do you differentiate them?
Dysarthrias, they can be caused due to dysarthrias means the peripheral nerve problems, sir. Whereas dysphasias are due to central problems, sir. Dysarthrias are due to like peripheral articulation defects involving the usually 7th, 12th nerves, 10th nerves.
Yeah, you're almost there, Srivardhan. Good. So aphasia is different, dysarthria is different. Aphasia is a central problem. Like as you say, Broca's area, Wernicke's area. When there is lesion in the Broca's area, there will be a difficulty in initiating. Fluency will be affected. Naming will be affected. Wernicke's, usually they'll have comprehension difficulty. This is aphasia. Aphasia is different, dysarthria is different. Again, what you're talking about, dysphasia is different. Dysphasia is developmental problem in developmental problem in pediatric group that we are not talking about. Okay, aphasia, yes, dysarthria. Now I'm asking, what are the types of dysarthria you know?
Maybe due to facial nerve involvement, facial type of dysphasia can be seen, sir. Due to tongue involvement, it can be seen, sir. Due to 10th nerve involvement, it can be seen, sir. And due to cerebellar involvement, it can be seen, sir.
Right, good.
And, yes, sir.
Spastic dysarthria is also one more entity where we rarely see it. In case of bilateral strokes or in yes, pseudobulbar palsy or bulbar palsy, we see spastic type of dysarthria. Like something has kept some, the mouth is full, like anyone speaks with pan inside or chocolate inside. This is a kind of dysarthria we describe. So, whereas cerebellar dysarthria is then we, as a drunken person speaks, like they'll have high pitch, low pitch, and breaking of syllables. That is a characteristic of cerebellar dysarthria. Whereas, as you have said, 7th, 9th, and 10th can also produce dysarthria because of articulation of the lips and tongue and posterior pharynx respectively, right? Yes, so what does your patient has? Anything we can differentiate on this based on history?
Actually, in history, I have asked about 7th and 10th nerves and 12th nerve, sir. He is able to swallow the food properly, so the 12th nerve is intact, sir. And he's able to, he's not having any nasal regurgitation or nasal twang, sir. So his probably his 10th nerve is also intact, and he's not having any visible deviation of mouth and no drooling of saliva. So his 7th nerve also seems to be intact.
Sure. Okay. So 7th, 9th, and 10th are normal according to your history.
Yes, sir.
Only there is slurring of speech. Probably now you're left with cerebellar dysarthria or spastic.
Yes, sir.
Hello?
Yes, sir. Hello, sir.
Yeah. Okay, let's see your examination and further history. Now, what is your next point? Weakness of right upper limb and lower limb.
Yes, sir. Weakness of right upper limb and lower limb, which was sudden in onset, sir, which was gradually progressive, and it is associated with swaying to left side, sir.
Yeah. What is the swaying to left side? So where do you want to?
He is speaking. He is speaking that he is telling that while he was walking, he was slightly swaying towards left side, sir. And his gait
what-
is also
What is
cerebellum.
So in
what is-
cerebellar lesions, you want to say that there is will be swaying to one side.
Yes, sir.
Okay. So can you label the parts of cerebellum? In which part of the cerebellum there will be deviation to one side, swaying to one side? Okay, probably. See, inferior cerebellar peduncle, there is vestibulocerebellar tract. In that there will be swaying to one side, and cerebellar hemisphere lesion also can produce swaying to one side. Hello, am I
Hello,
audible?
sir. Inferior cerebellar peduncle.
Inferior cerebellar peduncle connects vestibular nucleus to the cerebellum. What is the tract? Vestibulocerebellar tract. Lesion here can produce swaying to one side. Okay, and cerebellar hemisphere, like you have a cerebellar vermis, paravermis, and hemisphere. So in cerebellar hemisphere also you have swaying to one side, but they will have, in addition to swaying, marked incoordination in upper limbs, like finger nose ataxia will be there. Maybe you don't have any positive history to say that there is upper limb ataxia, right? You did not mention
sir.
anything about it. Only swaying
sir.
is there. So
Only
maybe
swings.
by looking into your history, that localizes to vestibulocerebellar tract or inferior cerebellar peduncle. And what you are saying is no vertigo, only dizziness and weakness of right upper limb and lower limb, and slurring of speech is there, which is not contributed by facial and 9th and 10th, right?
Yes, sir.
Okay, let's see. Yeah, go ahead.
In my examination,
No, Srivardhan. See, in neurology, we describe the symptoms, right? And we localize anatomically. Based
sir.
on the anatomical localization, we give the anatomical diagnosis, then etiological diagnosis. This is how neurologists dealt. Now, in your
Yes, sir.
differential diagnosis, you have each symptom, you give different localization, which is not possible. Okay. See, in right side weakness, you are localizing to, and again, you have given facial nerve involvement is there. You said there is no facial. Can you give me some history which shows that there is facial nerve involvement?
Actually, based upon history, I couldn't find any facial nerve involvement, sir. But I thought it could be.
Again, you kept a question mark that there is secondary to facial nerve involvement.
Query,
Is there any deviation of mouth? Is there any deviation of mouth?
No, sir. No.
No. Okay. If it is,
But he was not. No, sir. Actually, he was not able to see the deviation of mouth. But on examination, it was there, sir.
In these cases, in this scenario, maybe you can give the history. When you are sure that you have facial nerve involvement on examination, probably you can ask the attenders and add in the history. So because your slurring of, again, your anatomical localization becomes completely different, no? My point is you have to mention facial nerve involvement in history.
Okay, sir.
Okay. So there is facial deviation onto which side, right side or left side?
Facial deviation was towards the left side, sir.
There is right upper limb and lower limb weakness with deviation of mouth to the left side.
Yes, sir.
Okay. Means there is right-sided weakness, right?
Yes, sir. Right-sided weakness.
Right facial weakness. Are you sure
Right
there is a deviation to the left side?
Yes, sir. The deviation was towards the left side, sir.
Now, can you tell me what happens to the deviation of mouth in 7th cranial palsy, 5th cranial palsy? How it is different?
Sir, if there is a cranial nerve involvement towards one side, the mouth will be deviated towards the opposite side, sir.
In which cranial nerve?
Seventh nerve palsy. If there is a cranial nerve involvement, the nerve will be the face will be deviated towards the opposite side, sir. Because the opposite sides muscles are working. Opposite side facial muscles are working. It will be deviated towards the opposite. Yes.
What happens in 12th cranial nerve palsy? Where it will, if you ask the patient to protrude the tongue, what happens to the tongue? It deviates to the same side or the opposite side?
12th, it will be difference based upon supranuclear or
No, there is no difference supranuclear and intranuclear. Hello?
hello, sir.
It is to the same. Any exam going PGs?
Third year PG is Dr. Sara. Anyone?
So remember like this, 12 and 5 deviates to the same side of the lesion. Okay. 7 and 10, 17. So they deviate to the opposite side. Okay. Got it, Srivardhan?
Yes, sir.
Okay. 12, 5 deviates to the same side of the lesion, whereas 10 and 7 deviates to the opposite side. Okay. Hello.
Got it,
Hello,
sir.
sir.
Yeah. Now, see, you have given three different anatomical localizations for three different complaints. That is not correct, Srivardhan.
Actually, I thought it can be due to left internal capsule because of this right-sided weakness and slurred speech, sir. And swaying towards left side, maybe I thought it was due to because his right side was weak and his left side was normal. Maybe he was swaying to the left side, sir. And the second diagnosis, which I kept as cerebellar stroke, I kept it because he's having giddiness and he is swaying towards left side, and slurred speech or scanning speech can also be seen in cerebellar ataxia. That is also explaining all the three symptoms, sir.
No. See, you have to explain each symptom and you conclude from your side and give your anatomical diagnosis and etiological diagnosis. It is clearly apparent the etiological diagnosis, acute ischemic stroke, maybe thrombotic. Okay, I accept it. But anatomical diagnosis based on your complaints, you have to localize and give your anatomical diagnosis. So you cannot give three different places for three different complaints. Okay, let's go in this way. If any, I think some final year PG is trying to unmute herself. Virup, can you unmute her? Maybe she wants to say something.
Madam, please unmute Dr. Sara.
Yes, ma'am. Good evening, ma'am. Actually, I was just saying that 12th nerve palsy will be deviated to the same side of the lesion.
Okay, have you seen this case?
Yeah, no, ma'am. I didn't see that case.
Okay, Srivardhan. So let's go from this way. So what are the features of internal capsule stroke? What are the features of cerebellar stroke? What are the features of Fontan stroke?
So
Maybe Sara can answer this. She's a final year PG now. One by one. So what happens in Fontan stroke? Where do you localize? What are the features of Fontan stroke? Okay. See, medial. Yeah, go ahead. Someone is speaking.
Yes, sir. So in Fontaine strokes, usually we have like fifth, sixth, seventh cranial nerves, sir, and so we can have pinpoint pupils and rise of hyperpyrexia can be present, sir, and there can be cerebellar peduncle involvement and ataxia can be seen in Fontaine, sir, and the seventh nerve involvement. I kept it as differential here because he's having slurred speech because
No, Srivardhan, don't go into your history right now. So what you're trying to say is 5th, 6th, 7th, 8th.
Yes,
This depending on the location, any of the four cranial nerves can be involved, right? And the vestibular nucleus is also located in the pontomedullary junction, and we have this we have pyramidal tract going through the pons. So patient can have weakness, hemiplegia, that is hemiplegia. Any of the cranial nerves, 5, 6, 7, 8 can be involved, and if there is vestibular nucleus involvement, there can be vertigo. Now, does your patient fit in this order of symptoms? You
Yes,
said
sir.
you have seventh cranial nerve, but
sir.
you says that it is onto the same side. Right hemiplegia is there and right facial is there.
Yes,
Your
sir. It
patient
is
has
not
that.
like uncrossed. It is not typically like a brainstem hemiplegia, sir. Crossed hemiplegia, sir. It is
No. So this is not, see, in all brainstem stroke will not produce crossed hemiplegia, right?
Yes, sir.
See, there is, you know that there is some anatomical variation from person to person. Patient may have anywhere in the pons. After decussation of facial nerve, there can be stroke. Before decussation of facial nerve, there can be stroke. So that doesn't point that he does not have any fontan infarct. Okay. So
Okay.
if there is that, we take it. If there is crossed hemiplegia, then we can consider brainstem stroke as a differential. But it doesn't mean that if there is no crossed hemiplegia, no brainstem stroke.
Yes, sir.
Okay. Got it?
Yes, sir.
Okay. So based on the level of stroke before or after decussation of facial nerve, we get. Okay.
Yes, sir. So if my lesion is in pons, I can explain the right-sided weakness and right-sided weakness of upper limb and lower limb, and right-sided weakness of face and slurring of speech, sir. These three can be explained by pontine involvement, and I can also explain the vertigo, sir. Dizziness, sir, because the vestibular nucleus is located there. And sir, I have a doubt. Can we explain the ataxia part with the pontine lesion, sir?
Yes, I have told you no. You did not mention any ataxia. Let me summarize. So if there is inferior cerebellar peduncle, that is vestibulocerebellar tract, definitely you will have ataxia. More than ataxia, you get swaying towards one side. Okay. In Vermean and paravermean strokes of cerebellum, you get gait ataxia and truncal ataxia. Okay. And anterior of lobe of the cerebellum, if there is stroke, you get gait ataxia without vertigo. Okay. These are the differences for acute onset of gait ataxia. Got it?
Okay, sir.
Okay. So your patient can have inferior cerebellar peduncle, vestibulocerebellar tract, pontine area stroke. If provided your history taking is correct in the to say that he has vertigo, he has right-sided weakness, right UMN facial nerve palsy, and swaying towards one side or gait ataxia. Okay. What are the features of internal capsule stroke?
So we will have dense hemiplegia, sir. Like the upper limb and lower limb involvement will be equal, sir. We will have the contralateral hemiplegia, and associated with the corticobulbar fibers were also involved. We can have a facial nerve involvement too.
Okay. Is it always that the upper limb and lower limb are equally affected? It is always like that?
Usually, we typically describe it as dense hemiplegia, sir, which means upper limb and lower limb weakness will be equal, sir.
It's not always like that. Read about the anatomy of posterior limb of internal capsule. Okay.
Okay.
Okay. Now, so your likely anatomical structural localization is towards the pontomedullary junction, probably involving the inferior cerebellar peduncle, probably, which explains all your symptoms. Let's see whether you have whether we are correct or wrong. Okay. Cerebellar stroke, I have explained the features. No, if there is Vermean, paravermean, and cerebellar hemisphere, that will be different. Okay. So, if any doubts regarding this history taking in any other final PGs want to add anything or ask anything? Shall we go ahead then?
Yes, sir.
Yes. Yes, madam. Please go ahead.
No, I
No,
think
no, Srivardhan.
you have
Madam,
to.
if we have time, madam, if we have time, can we take 5
Yes, sir.
minutes
You can
for our
correlate
examination?
yeah, you can correlate the history with the examination findings, so it will be useful for the PGs a little bit quick if you don't mind. And
Yes,
then
madam. 5
we
minutes.
can move
Yes,
on to
madam.
management.
Sure, sure. Definitely. In the examination, show me the examination slide, Srivardhan.
So the higher mental functions were intact, sir. Apart from dysarthria, the patient he speaks with gaps as if the words were measured or scanned, and the patient had also difficulty in pronouncing labials, sir.
Labials. That points to facial palsy. Okay, right. Okay.
And the patient is having a loss of nasolabial fold on the right side, sir, with deviation of more towards the left side. But the patient is having able to wrinkling present bilaterally on the forehead, and he is able to close the eyes properly against resistance. And his remaining cranial nerves were intact, and his motor system tone was elevated on the right side, and it was normal on the left side. And his power, it is 4/5 on the right side, and it is 5/5 on the left side, sir. And his reflexes, plantar was extensor on the right side and flexor on the left side, sir. And abnormal reflexes were absent on the right side and present on the left side, sir.
Okay, Srivardhan, I assume that you read up what are the difference between LMN palsy, UMN palsy. So how are the reflexes in LMN, UMN, and facial nerve root, anatomy of facial nerve?
Yes, sir.
Hello? Yeah, read up all this. Okay.
Yes, sir.
Because of we are lacking of time, I'm not discussing. Okay, right.
Okay.
Now we'll go to. I have seen the summary of your summary slide. You have cerebellar signs, right?
Yes, sir.
Yeah. What are the positive cerebellar signs?
He's having finger nose test and heel shin test, which is positive on the left side, sir.
Okay.
And he's having pass pointing also positive on the he's able to not localize to the finger, but he's going more than the finger on the left side, sir. And he's not able to perform rapid alternating movements with the left hand, sir, properly. And he's also having swaying to left side while walking, sir. But he's not having any nystagmus, sir.
Okay. Okay.
And okay.
Yes.
So actually, we thought it was internal capsule and cerebellar stroke, sir. When I presented to the neurologist about this case, he told that we do not have like two different circulation strokes at the same time. Usually it may be due to another explanation. Then we actually admitted the patient, and initial management what we did was according to the AHA-ASA guidelines 2019, we did an ECG to rule out whether any cardioembolic stroke or any MI or any atrial fibrillation or anything. And we did his random sugars, whether any hypoglycemia or anything. So, and we did his MRI brain, sir. Actually, he presented to us at, he had symptoms at morning, sir, at 11 a.m. 11 a.m., 10 a.m. He's having symptoms. He presented to at night 10 a.m., 11 a.m., sir. His, we calculated his NIHSS score, sir, National Institute Health Stroke Scale, sir, which was 6. The patient he did not fall into category suitable for revascularization procedures such as thrombolysis or mechanical thrombectomy, sir. He's having actually, we did an MRI which revealed a left pontine infarct, sir.
Okay.
So we have started him on aspirin therapy according to guidelines, and we continued his statins, and we have monitored his sugars and blood pressure, and we have he's able to swallow. So we deferred Ryan's tube placement. He underwent daily physiotherapy, and we did the carotid Doppler as it was an ischemic shock according to the guidelines, which showed mild epinomatous changes in the bilateral common carotid arteries. and the patient was discharged 4 days later, sir.
Okay.
Sir, your opinion over here, Dr. Sangameshwar sir.
Yeah. Nice case presentation, madam. Nicely managed. Yeah. I think filer PG should more involve in discussion. Madam, CNS case is a long case for them?
Yes, yes, sir, it is a long case.
It is a long case. Achha. Okay, okay. It is more.
Yes, is a long case, sir, for us family medicine, and usually the case taking will be and the viva will be like more than MBBS stage and less than the general medicine. Yeah.
Achha, achha. Okay, okay. Probably, yes. I think only basics maybe we have missed is that is LMN, UMN type of weakness that has to be taught, and pathway of facial nerve. Simple, all the cranial nerves need not be answered. At least facial nerve they have to know. And differentials, maybe probably if there is a neurologist, he expects anatomical localization and etiological diagnosis. Maybe they have to do like this. They can't have two localizations, or else everything is good. They're right on track.
Would you like to kind of elaborate on the anything management wise? Like, let's say similar patient comes to the clinic for the first time, and we have seen, I mean, for the new PGs who pass out and just start their own practice, so they come up with this sort of case. So what would be the first thing we have to do, kind of things?
Yes. Definitely, if you are suspecting a stroke, in first 4.5 hours, there is unless and until if there is contraindication, thrombolize the patient. For thrombolizing the patient, you need to have a CT. You need not have an MRI. So rush the patient to the CT. If there is no bleed, if there is no infarct seen on CT, thrombolize the patient. Provided there is no contraindications, there is no bleed on CT, then go ahead thrombolizing the patient. Then start antiplatelets accordingly and do an MRI. Go for other investigations like PTA, PTT, CBP, RFT, electrolytes, GRBS. Only thing which needs.
Let's say if we are practicing in a remote area, sir, would you like us to give aspirin and clopidogrel duo before we ship the patient to the hospital from a remote place, or like where
definitely. Yes.
So how much aspirin and clopidogrel, just for the knowledge sake of PGs?
Yes. Yeah. The loading dose of aspirin is 325 mg as it was given here, and clopidogrel you can give 150 mg is enough, and statins 80 mg.
And clopidogrel 75, sir. Did you say 150?
150 we give clopidogrel, aspirin we give 325 mg, statin loading doses atorvastatin 80 mg. This is the loading dose we give, unless and until usually there are no contraindications for antiplatelet except IC bleed. So always confirm with CT. If there is no choice of taking a CT, probably you can give a single dose of statin and 325 mg of aspirin and shift the patient to the nearby CT scan center.
Okay.
If you are staying in a remote area. But it is always wise to do a CT, then give a loading dose of aspirin and statin.
Yeah.
So always heparin contraindicated.
Sorry, Viru, yours.
Always heparin is contraindicated in acute case.
Yes. Now, of late, now we are not using heparin for acute ischemic strokes. The latest guidelines, heparin is indicated in only 2 conditions. That is venous stroke. Second one is the patient is having AF throwing in the active embolus to the brain. Only these 2 conditions we give heparin. Otherwise, all other ischemic strokes we don't give heparin. This is the latest guideline.
Thank you, sir.
Sir, if it is a dense hemiplegia, or you see that the patient is having ongoing stroke symptoms, I mean, is it still advisable to give aspirin and clopidogrel, considering the transit time may be higher? Because if it is a hemorrhagic stroke, are you risking the patient more?
Yes, madam. In this scenario, when there is no CT available, you have seen the patient with dense hemiplegia, and maybe he's 4.5 hours, 5 hours away from your referral center, probably you can try. We have given loading dose of aspirin, but don't give dual antiplatelets. Give one single antiplatelet with aspirin and shift the patient. If you're not sure whether it is hemorrhagic or ischemic and CT is not available.
Okay. So 325 mg of aspirin should do that.
Yeah, this is off-label what we are doing, but
Okay.
there is no definite guideline for this one.
Right.
Probably you can give 325 mg aspirin and send it.
Okay. Any other questions from the participants? Srivardhan, is there anything left in your presentation? Sorry, I didn't see. You had some more slides, I guess.
Actually, when I went to my neurology sir, ma'am, he told like what sir was telling, he also told like the same thing, ma'am. He told like he told like this Occam's razor concept, ma'am, like a single explanation that explains all findings is more likely. Like sir was telling like only Fontaine thing can explain all the things, whereas I was explaining it with both IC and cerebellar strokes. Like my neurology sir told these things, ma'am.
So is that end of your presentation, Vardhan?
Yes, ma'am.
Anybody else wants to ask any questions to Dr. Sangameshwar?
Exam going PGs and participants.
If there's an issue with unmuting, please type in your question in the chat box too. I'm sure neurology is a complex topic. Srivardhan today has taken the edge. I think he has done very well considering being a PG, first year PG.
Yeah. He has done a good job,
Yeah.
better than a first year neurology PG.
Kiranmai, ma'am, you want to add anything?
I mean, it's a wonderful discussion, sir, and especially what you say is completely true. Localizing the lesion is very important, and for PGs, especially. Be confident when you are presenting, and when you are thinking that sign is present, you don't have to manipulate it according to the symptom presentation, or if you think that sign will change your diagnosis, probably you shouldn't do that. You should still stick with your signs and symptoms. So be thorough with your symptoms, elicit a good history. History is very important in neurology, and it gives you probably 75% of the answer, especially with history. So that's very important, and make sure and see if it kind of correlates with your examination findings. So it's a very difficult topic actually, and thank you, Dr. Sangameshwar sir. I think you've done a lot of help to us, especially it's like a revision for us too, going through all the infarct locations and the lesions and the symptom presentation at different locations.
Yeah, my pleasure.
Thank you, sir.
Thank you.
Thank you.
Thank you so much.
Anything else?
Ma'am, is there any rule of clopidogrel according to SCCAH guidelines? When I was going through, they have mentioned only it's regarding only aspirin. They have mentioned, ma'am.
I think Dr. Sangameshwar, I've seen aspirin and clopidogrel in the treatment in the guidelines, in the AHA guidelines.
So
Is that
for
right?
dual
Dual
antiplatelets. So aspirin is the first line antiplatelet. So based on the NIHS score, we decide whether we are going to give dual antiplatelets or single antiplatelet. So in patients when
Within
there
the
is
first 24 hours, is there any evidence, sir, like clopidogrel?
Yes. See,
Yes.
that depends on entirely the size of the infarct. So what happens if you give too much of antiplatelet is there is risk of hemorrhagic transformation, edema, and worsening of the patient. So first in 72 hours to 7 days is the area where patient deteriorate because of edema and hemorrhagic transformation. So in that period, if you want to give dual antiplatelets, the indications are the size of the infarct is less. So like NIHSS score of 6 to 8, below 6 to 8, then you can give dual antiplatelets. And the patient has stenotic lesions in the carotid artery. If the patient is not going for surgery, then you give 3 months of antiplatelets. Only these two are the definite indications for giving dual antiplatelets. Again, the duration varies. If the NIHSS score is less than 6 to 8, you can give only up to 21 days, then shift to single antiplatelet. If the patient has carotid stenosis, not going for surgery, if you want to give platelets, dual antiplatelets for 3 months. This is the only two indications, definite indications for dual antiplatelets. And TIAs also we give dual antiplatelets. Transient ischemic attack.
Sure. TIA again is a very, very frequent presentation, which PG should be very wary of. And as family physicians, we do see quite a few every month. Right.
Any more questions, or shall we wind up?
I think we should wind up, Virup. Oh, there is one question. TIA lifelong, we should give dual antiplatelet. Okay, for TIA, should we give dual antiplatelets for lifelong? That's the question, sir.
No. It is just like a minor stroke, which is NIHSS of less than 6 to 8. So we give for 21 days, then we assess the risk. If the patient has any stroke again, based on that, we'll continue. Or else, if the patient is not having any stroke in next 21 days, we shift to single antiplatelet. That's it.
So 3 weeks is the limit for TIA.
Yes.
Do we continue them on single antiplatelet after that?
Yeah, yes, madam.
For
We
lifelong?
continue on. Yes, we continue on the single antiplatelet.
Right.
Thank you.
Yeah.
Thank you very much, sir. It's a very beautiful discussion, and you have made it very simple for us. And I think the presentation by Vardhan is great, and he did very good for being a first year PG, and I congratulate him for that. And Kiranmai ma'am, and thanks for actively participating in the discussion and making the discussion more interesting. And today's session went very well. And I would like to thank the National Chair, Dr. Serin sir, and the National Secretary, Dr. Jyotika ma'am, FM360 Coordinator, Dr. Hiren Kurya sir, and us, sir, for joining today's session and giving us the platform for reaching all the PGs and making it success. And I want to thank the state leads, Dr. Gunjan and Ali Jamil, for joining. And I want to thank the Dr. Srinivas sir, the National Director of AFPI National Executive, for joining today's discussion. And thank you very much, everyone, for joining today's discussion. And at last, thank you, Sangamesh sir, once again for joining us and giving us all the clues and the Viva questions and how to take the localization part and how to differentiate the cranial nerves involvement and all these things, points. Thank you, sir. Thank you, everyone.
Thank you so much.
Thank you, everyone. Thank you, Team Telangana. Thank you.